Treatment of hepatocellular carcinoma. I am Dr. Jorge Marero, Keith Henley, Collegiate Professor of Gastroenterology at the University of Michigan and a staff physician at the Ann Arbor VA Medical Center. In terms of disclosure, I received grant funding from Bayer, Onyx, Bristol Myers, and Pfizer. In order to discuss the treatment of hepatocellular carcinoma, we first have to discuss the malignant transformation of this tumor. When there is a chronic liver injury, such as hepatitis C, hepatitis B, ethanol, or non-alcoholic fatty liver disease, over time, the liver develops a lot of fibrosis and inflammation, and then it develops cirrhosis of the liver. Once cirrhosis develops, then it leads to dysplasia and then cancer development. When we are evaluating patients with hepatocellular carcinoma, we have to deal with two processes that are going at the same time. One is the liver disease itself, or the cirrhosis, and the other one is the tumor. So that's very important to understand for this tumor, and it's what makes it unique compared to other tumors. Before considering treatment, we have to discuss the staging. There are several staging systems associated with cancer. A lot of them have relied on pathology or tumor burden. Because we're dealing with a tumor that also has an underlying liver disease, the best staging system out there is the Barcelona Clinic Liver Cancer Staging System. It is important because it takes into account liver function, it takes into account performance status or how the patient is feeling, and it takes into account the tumor burden. So based on the tumor burden, the stages are classified from 0 to A, B, C, or D. The earlier stages are 0, or carcinoma in situ, stage A. Stage B is an intermediate stage, stage C is an advanced stage, and stage D is a terminal stage. So from now on, we're going to discuss the treatments for each staging system. Very early HCC, or stage 0, is when there is a single tumor less than 2 centimeters, and the patient has normal liver function and is doing quite well without symptoms. The best treatment for this stage is resection, and there are several large series of resection for this tumor throughout the literature, the largest of which was in 2004 in Japan, and it shows a study of over 10,000 patients that underwent resection. What this study shows is that resection for small tumors, especially less than 3 centimeters, can lead to significant 5-year survivals of over 60%. One of the important things with resection is that we have to take into account the liver function. A different study evaluated the outcome of patients with hepatocellular carcinoma after resection. Those that did the best were patients that did not have clinically significant portal hypertension, have normal bilirubin, and felt well. Those had 5-year survivals over 70%. However, those that indeed had clinically significant portal hypertension or a bilirubin that was elevated, their 5-year survival was poor. So patient selection is critical to recommend patients that undergo resection. One of the important things with resection is that, unfortunately, less than 5% of the patients with this tumor are going to be eligible for this kind of treatment. The next tumor stage is early HCC, and these are patients that have a single tumor between 2 to 5 centimeters in diameter or have up to 3 tumors, each of them less than 3 centimeters. The best treatment option for this tumor stage is liver transplantation. There's a landmark study in 1996 by Mazzaferro who evaluated 48 patients that met a specific criteria. That criteria was a single tumor less than 5 centimeters or 3 tumors, each of them less than 3 centimeters. And that is the so-called Milan criteria. When the patients met this criteria and underwent liver transplantation, their 4-year survival was 78% and with only an 8% recurrence rate. This study changed the landscape for liver transplantation, and most countries adopted the Milan criteria as the main criteria to evaluate patients that undergo liver transplantation for this tumor. In the United States, there have been a large study to evaluate over 4,000 patients that underwent liver transplantation. Those that met the Milan criteria did much better than those that exceeded the Milan criteria. So strict adherence to this criteria improves outcomes. The main limitation of liver transplantation for hepatocellular carcinoma is organ availability. The number of transplants done in the United States over the last 8 years has plateaued to about 6,600. Therefore, there's not a lot of livers for everyone. So strict selection is needed, and other kinds of therapies are also needed in order to bridge patients to transplant or to treat them as their primary therapy, given the fact that we cannot do a transplant on every patient. Therefore, another treatment that has been available is percutaneous ablation. There are two forms of percutaneous ablation. One is radiofrequency, in which a catheter is placed into the liver. The catheter then engulfs the tumor and applies 100 degrees Celsius, and that causes coagulative necrosis. Another type of ablation is percutaneous ethanol injection, in which a needle is guided into the tumor, 100% ethanol is injected, and it also leads to coagulative necrosis. There have been several randomized trials that have compared percutaneous ethanol injection versus radiofrequency ablation. In terms of complete response rates, or CR, RFA or radiofrequency ablation has a higher complete response rate compared to percutaneous ethanol injection. In terms of the number of sessions required in order to lead to a complete response, RFA does this coagulative necrosis in less number of sessions compared to ethanol injection. And 3 of the 4 studies showed a survival advantage for radiofrequency ablation over ethanol injection. Therefore, RFA is the main modality for percutaneous ablation. And RFA can lead to 5-year survivals of over 50%. So, resection, liver transplantation, and radiofrequency ablation are considered curative therapies. Because radiofrequency ablation works so well, it has been compared to resection. There is a randomized controlled trial in China that compared radiofrequency ablation versus resection. 71 patients were randomized to RFA, and 90 patients were randomized to resection. All the patients had child class A, and all of them had tumors less than 3 centimeters. After a follow-up of 3 years, there was no difference in overall survivals among the 2 groups. The conclusions of this study showed for the first time that RFA and resection can lead to similar survivals. Therefore, right now, in terms of recommending RFA versus resection, it is really based on the tumor location, how the patient is doing, the liver function. All of those will enter into the equation when deciding when to do radiofrequency ablation versus resection. Also, another important aspect is the local expertise. If there's a specialized surgeon, then resection may be a better option compared to RFA. Another tumor stage is the intermediate stage, and these patients can have multifocal disease, that they have more than 2 lesions that exceed the Milan criteria, or they can have multifocal disease, as shown in this slide. The best treatment option for patients with intermediate stage HCC is chemoembolization. Chemoembolization is a procedure in which the hepatic artery is cannulated, an arteriogram is obtained, the blood vessel feeding the tumor is identified, and then chemotherapy is injected into the tumor, followed by embolizing the feeding artery to the tumor. So it's a 2-pronged approach in one setting. There have been several randomized trials and several meta-analyses. The meta-analysis of the randomized trial showed that there's an overall survival benefit of chemoembolization versus supportive care. The survival advantage is modest at improving the 2-year survival compared to doing nothing. Some patients do have a significant response compared to other patients. A new form of chemoembolization has been developed, and it's called the drug-eluting bead TACE. The conventional TACE or chemoembolization had been a mixture of chemotherapeutic agents, either mitomycin, doxorubicin, and 5-FU. That mixture is then injected into the tumor, and then the artery is embolized by gel foam or particles. That is the conventional TACE. The drug-eluting bead TACE are these beads that are about 500 micrograms in size, are loaded with doxorubicin, and then injected intraarterially into the tumor. That has the advantage of not only delivering the chemo into the tumor, but also at the same time causing an embolic phenomenon. Another advantage is that the amount of doxorubicin in the blood is much less compared to the conventional TACE. Therefore, it leads to better tolerability and less side effects. Another form of intraarterial therapy is radioembolization with Y90 or yttrium-90 microspheres. This is also requires an intraarterial catheter going into the hepatic artery, and instead of delivering the beads loaded with chemotherapy or doxorubicin, these microspheres or beads are loaded with Y90, which is a radioactive material. These radioactive particles are then injected intraarterially into the tumor, causing necrosis. There is no randomized trials showing an efficacy of Y90, but there are large case series that have shown a significant response. At the moment, Y90 is reserved for those that are not eligible for chemoembolization or who fail chemoembolization. A randomized trial of Y90 is actually being done. The next tumor is an advanced hepatocellular carcinoma, and these are tumors that are large, and one of the hallmarks is invasion into the portal vein, as is seen in this slide. Over the last decade, significant advances have been made in the determination of the intracellular pathways that lead to cancer. One of those pathways is the RAF kinase pathway. And this pathway, when it's stimulated, it stimulates the nucleus to produce these cytokines that in turn leads to angiogenesis, tumor proliferation, and tumor growth. Sorafenib is an agent that has been developed that blocks the RAF kinase pathway, and therefore it has the effect of inhibiting angiogenesis at the level of the tumor and at the level of the blood vessels, and also inhibits cellular proliferation and growth. Before the development of sorafenib, we had systemic cytotoxic chemotherapy that in different studies were never proven to be of benefit in hepatocellular carcinoma. So therefore, there has been a significant need for development of newer systemic agents. A phase 3 trial of sorafenib for advanced HCC has been performed, and this trial randomized 299 patients to sorafenib, 400 milligrams BID, and 303 patients with advanced hepatocellular carcinoma to placebo. As you see in the survival curves, the patients on sorafenib had a significant improvement in survival compared to those with placebo, with a difference of about 3 months. When this graph was obtained, the Data Safety Monitoring Board stopped the study early, and all the patients on placebo were then switched to sorafenib. Sorafenib also delays significantly the progression of this tumor compared to placebo. In terms of the side effects, the most important side effects are diarrhea, hand and foot skin reaction, anorexia, and fatigue. Those are the major side effects that have to be dealt with this agent. At the moment, sorafenib is the gold standard for systemic therapy for patients with advanced hepatocellular carcinoma and is the first-line agent. In terms of the future, there are many other intracellular events that have been identified in hepatocellular carcinoma, and newer drugs have been developed that have blocked these different pathways that lead to cancer. This is a very active area of research, and newer medications are being studied as we speak. So the future is very bright in terms of developing new agents for hepatocellular carcinoma. So to conclude, curative therapy for hepatocellular carcinoma includes resection, liver transplantation, and RFA. Transarterial chemoembolization is the treatment of choice for intermediate stage HCC, and sorafenib is the treatment of choice for advanced HCC. And newer trials are being done of newer agents and combination of systemic agents with local therapies such as transarterial chemoembolization.